Okay, when we talk about perioperative nursing, what we're talking about is that entire process from the time that the doc says, hey, you need to have a surgical procedure, to the time that the patient has returned to their current level of functioning, or better than their level of current level. So it's divided up into three different time frames, I guess you would call it, and you have 3 chapters that coincide with those time frames, okay? Preoperative nursing is really the time from when the doc says you got to have surgery till the patient actually goes to the operating room. Okay? So that may be from the time the patient is in the doctor's office to the time the patient is admitted to the hospital. It just, depends on when they make the decision for surgery. And then Chapter 17 covers intraoperative. That's the time that they're actually in the operating room, whether it be in the holding area, which we'll talk about, or in the to the end of the surgical procedure. Post-op is Chapter 18, and that's really kind of the meat of the operative stuff, because unless you're working specifically in the operating room, you're mainly going to be concerned mostly with the preoperative process and the post-operative. Intra-op is a very, very involved, highly technical area of nursing, and it's one of those places that you either love it or you hate it. It's kind of like OB. You either love that or you hate it. So the meat of our discussion is going to be in Chapter 16 and Chapter 18. We'll talk about 17, but just so that you kind of know what's going on. But when we're looking at preoperative and postoperative, the time that the patient gets through with surgery to the time the patient, like I said, recovers and is back at their best level of functioning, that's the postoperative period. Those are the times that you guys are really, the majority of nurses are highly involved in care in those 2 points in time, okay? Did anybody read those chapters in your spare time since Monday? You looked at? All right, good. You've already, okay, good, all right. Yes, okay. Okay. The surgical process in perioperative nursing, I want you to understand is that there are so many risks to the patient. Okay? And it's such a, people who work in pre-op areas, same-day surgeries, the operating room, it's a flow. It's a flow of patients, and it's almost like herding them through the cattle thing. They do one, move on, and they have their procedures and their policies and everything set. These are some highly technical people, and the process has got to move, okay? So it's a lot of, while they may think, and we may think it's just a surgical procedure, it's a big deal to your patient. How many in here have ever had surgery? Actually been put to sleep? Yeah, was it a big deal? You betcha it was. It sure was. Because you're putting that patient completely out if they're gone to sleep, okay? They're not breathing on their own. They have no muscle control. They're gone, right? So you're depending on somebody else to know what they're doing. Yeah, and we'll talk about that. What he said was the anesthesiologist had a conversation with him, but if he was older than 60 or much younger, there would be a completely different conversation that they would have, because the risks are different, right? The older you get, the more risky you are, right? So because there's so many risks, we've got to do an awful lot of preparation for our patients so that they understand what's going on. We've got to be prepared, making sure that that they are ready, okay, that they understand and everything is done appropriately. Now, some of these things, keep in the back of your mind, some of these things can apply, that we're talking about, can apply when the patient is not necessarily having a surgery. Because when you think of surgery, you think of some kind of incision, that kind of thing. But a lot of this stuff applies when we're doing some of those invasive procedures that are going on out there. If we're doing a kidney biopsy, or we're having some kind of big radiological type of, liver biopsy or something like that, we still have to meet some of these same standards, especially when we're talking about pre-op, and of course they call it pre-procedural in that case, but we still have to meet some of those. The patient's got to know what's going on. We got to meet standards, and then post-op, our monitoring of the patient is the same. Remember we talked about those concepts? You still got to make sure your patient's breathing. I don't care what they had. You still got to make sure they're breathing. That's important, right? So one of the main focuses in perioperative nursing is safety, patient safety. And in your book on page 242 is a table that talks about the Surgical Care Improvement Program. SCIP. How many of you have heard the term core measures? What does core measures mean? You have to meet them. That's right. You betcha. You remember when they were talking, probably in 102, about certain standards that hospitals and facilities have to meet, and they come down from on high, from the government, from Joint Commission, those accrediting agencies that make sure hospitals are doing what they need to do. Well, because of patient safety, and because that is such a big issue, certain standards have been written that places have to meet in order to get their full reimbursement. You know how people can sign onto the internet now and see how their hospital or their doctor rates against somebody else? What they're looking at is, and where that data comes from, is how well those places and those physicians are meeting what we call the core measures. And core measures are simply things that have been shown to improve the patient's care, improve the patient's outcomes. So one of the things that was identified is that we have a lot of people that are getting into complications from surgical procedures. So they started looking at best practices. What are people doing that helps improves outcomes, yada, yada, yada. That's where SCIP came from. So it's a series of measures that that places have to meet now. So I want you to look at that, because if you're working in any kind of med-surg setting, you need to be very familiar with these, okay? And it's things just as simple as giving a patient an IV antibiotic within 1 hour of cut time, okay? You need to do it. You need to document it, because they're collecting data to make sure that you did it. And they found that patients are doing very well, okay, post-operatively when they had that. We don't need to give them 10 days of antibiotics before or after surgery like we used to do. That's why we got this MRSA running around out there now, right? So, giving them an IV antibiotic within the first hour before cut time, and then the other measures is that we actually don't carry the antibiotics out past 24 hours post-op, because the patient doesn't benefit from that. Okay, you give it an hour ahead of time. The antibiotics are in the system. They start when you have the cut. It's at top level. It starts to lay down when the wound starts to close. The antibiotic is in the wound matrix. So carrying it on along past 24 hours, the patient doesn't really get involved, get any benefit from that. Now, if it's a systemic type of infection, that's different. We're just talking about a post-op wound, right? So that's not your call, but you just need to know that these SCIP things are things that you will be doing and you will be held accountable for. Making sure that we've got the correct right versus left, because unfortunately left feet have been cut off when right feet should have been cut off. Okay, so that's one of those measures. That's a patient safety issue. Please don't take my wrong foot. That would not be good. So we have to make sure that everybody stops and everybody says, okay, this is Miss Kerr. Miss Kerr, why are you here today? Ms. Kerr lets us know, and we all have to stand around and make sure, I'm talking surgeon, anesthesia, all the nurses, and make sure that we all agree with Ms. Kerr. That's what she's here for today. It's called a timeout, and we'll talk about that. But it's a patient safety issue. Okay, so look at those things. Be aware of them. You might see them again. So look at them, all right? Okay, I'm getting off my soapbox. Let's move along. Surgical admission. Surgery nowadays can just really be done in a whole lot of different areas. We have a lot of routines and procedures. Your patient may be, the majority of folks now have same-day surgery or one-day admissions. They go in that morning, they have their surgery, they go to the house once they've recovered. Okay? It's an outpatient. 23-hour admits is another way. They bring them in that morning, have surgery, and the patient stays overnight. Okay? So what happens is they don't stay past that 24 hours and then it turns into an inpatient stay. This may be some of your patients who have maybe a hernia repair or a gallbladder surgery that you want to watch them overnight, make sure that they're good, stable, and then you send them home early the next morning or within the 23 hours. Inpatient admissions, y'all know what that is. The patient is admitted and stays over 24 hours. Insurance companies really don't like it, and there has to really be a good reason that somebody's going to come into the hospital the night before a surgery, because that's extra money. So they just don't let people just check in the night before because they need to rest. That don't happen no more. They usually come in that morning, just like an outpatient. They come in, they're put to bed, and then they're going to stay several days. A lot of documentation usually has to be done if the physician does want to bring the patient in earlier. Why do you think somebody would want to put somebody in a day or two ahead? Maybe they've got a big infection they want to treat beforehand. Maybe they're 90 years old and they're just not going to be able to handle that prep. Maybe they got a big prep to do. Maybe they don't have the mental capacity to do the prep and the pre-work that we need them to do. So lots of different reasons, but and it does happen. It's just not very, very common. And of course, you can always have people admitted as emergency for emergency surgery. Okay. All right. Classifications of your surgical procedures are really based on how serious it is, how urgent it is, and what's the reason. All right. You've heard major, minor surgery. To me, it's all major. If it's me, okay, I don't care what it is, it's major. But major surgery is usually those kind of surgeries that involve a pretty extensive type of invasive procedure. Okay, abdominal surgery, those type of things, orthopedic surgeries. Minor would be something with just a quick surgery, like having a carpal tunnel or something like that. You can use, you know what major and minor means. Urgency really goes into how urgent it is that your patient have that procedure. All right. Elective is it's really not essential at this point in time, and it may not be necessary for the health of the patient. Or it's really not. This would be somebody that's having a cosmetic procedure. They elect to have surgery. Okay. Urgent means urgent. It is a necessary procedure. It needs to be done. And having the surgery done may prevent them from developing additional problems. This is like, a gallbladder, a nasty gallbladder. It's got to be done. And then when the difference between urgent and emergency is emergency means it's got to be done now. Okay? It is a risk to the patient's health and life. This would be like if the appendix has ruptured and you've got bowel contents spilling out into the abdominal cavity. And that's not good. Okay. Your surgeries are also classified based on the purpose. Whole bunch of different kinds of purposes. Okay. Your book goes into detail about them. And pretty much the word is the reason. If it's diagnostic, we're going in there to do a surgery to see what is wrong with the patient. Okay, what is going on? That would be like what we call an exploratory laparotomy, where we just open the patient up and look around. Explorative, you're kind of doing the same thing, okay? But in this case, you're trying to find out also the extent of the disease. You're exploring to see, do I have, spread to other organs or, that type of thing. Curative means that we're removing something or we're fixing something to cure the patient's problem. We're removing the tissue. We may be cauterizing tissue. Fixing defects. We're fixing defects like a cleft palate or something like that. That's curative, but we're not removing anything. You're just curing the problem. Restorative means that you're doing the surgery to restore the patient's function. Maybe to restore their appearance. Okay, palliative is a surgical procedure that is done to ease a patient's suffering. Okay? It reduces the intensity of symptoms and the intensity of the disease. This is maybe somebody who has metastasis on a tumor that's blocking the ureter. Okay, so they may go in there to remove part of the tumor so that the kidney can now flow. Okay, or maybe they're removing part of something so that the patient doesn't have pain in that area. Maybe they're snipping a nerve or something like that. Okay, so palliative, yes. Yes, end of life is palliative. Yes. Sure is. Palliative just means you're easing the severity of symptoms. So palliative care at end of life, that's what you're doing. But palliative surgery, you're doing a palliative surgery to ease their symptoms. Okay? Same effect, you're just doing one is surgery, one's not. But it's still palliative. Okay, cosmetic, you guys know what cosmetic surgery is, right? Fixing whatever needs to be fixed. All right, those are usually elective, but in the case of trauma or something like that, that's not elective. It may be, an urgent or emergency type care. Transplant, putting in new organs, new parts. And then constructive is restoring function that's lost as part of a congenital process. Sure. Let me pull that right back over here so I can say exactly what I said. Restores function lost as a result of a congenital anomaly. Okay. That would be like a cleft lip, too. So some of them, they kind of cross over. Okay. So purpose, that's why they're having it done. So when we talk about surgical procedures, and we talk about how people are at risk when they're having surgical procedures, who do you think is more at risk? The elderly, right. The elderly, especially once a patient gets over 65. Okay, so we have to approach them, like Marcus said, we have to approach them a little bit differently. What are some of the reasons that a person over the age of 65 would be at an increased risk? Polypharmacy, what else? Respiratory function is not quite as good. What else? Circulatory is not quite as good. Everything's not quite as good, right? Okay. How about cognitive ability? Sensory ability? Okay. All those things play a role in how well your patient is going to do pre, intra, and post-op. Okay. Children are certainly at risk. Patients who are immunocompromised do not do as well with surgery. Patients who are overweight and or malnourished don't do well. Or it's not that they don't do well, it's just that they have a higher risk of complications. Okay? Patients with chronic illnesses like diabetes, hypertension, anemia, fluid and electrolyte problems. Those are a struggle sometimes. Patients with chronic respiratory illnesses. And then patients that are on certain medications have an increased risk. Patients that are taking a lot of blood pressure medications, patients who are taking NSAIDs, patients who are taking pain medicines, blood thinners, anticoagulants, absolutely. And certainly, the type of surgery that they have is going to put them at a bigger risk. So these things put them at risk, but you think about you've got an obese 70-year-old who has COPD, and they're having a big old abdominal surgery. Boy, that's really risk right there. So, head surgeries, neck, abdomen, chest, those type of big surgeries put your patients more at risk too. Okay? So, let's talk about the preoperative phase. From the time we decide we got to have surgery to the time we head to the OR. What do you think the focus is on your nursing care during that time? Think about your patient. What is your focus? Okay, make sure that they completely understand and know why they're having surgery. What else? Patient safety. Okay, what else? Get their baseline information. Absolutely. Good. Correct. Great. Making sure that they're ready. Making sure that they are ready for surgery. Your focus is preparing the patient. We do it with education. We've got to decrease their anxiety. We've got to make sure that they understand what they're going to have done. Our other issue is that we've got to identify, because we're getting our baseline data, those folks that are at risk with a goal to decrease that risk and to decrease the risk of complications. Identify and decrease the risk of complications. And so when we're doing care plan and we're setting patient goals, these are our goals. This is what we need to do. Make sure that we do. So your two basic, your two main, no, we'll get to that. I'll come back to that. Sorry. Okay, so let's talk about our preoperative nursing duties. First thing we do, nursing care plan, is what? We got to assess. All right, we've got to get a history. We've got to do a physical. Like she said, we've got to get some baseline data. You want to know all about your patient's health status. You want to know what their expectations are. Okay? What do they think they're having done, and why they're having it done, and what they think the outcome is going to be. Maybe they're completely off the mark. Okay? Finding their risk factors, clarifying any information, and clarify any education that they've had, because preoperative nursing really may start in the physician's office. You may be the nurse in the physician's office that's doing a lot of this pre-op education. Okay? It's because they hadn't even got to the hospital yet. Planning and implementing the care that they need, and then, of course, doing the interventions. So you're physically and mentally getting well, no, you're not, but you're getting the patient ready for surgery physically and mentally, is I guess the way I need to say it. When you had your surgery, did you feel like you were prepared? No? Was it planned procedures? And you didn't feel like you were prepared? What was missing? They didn't tell you that. Well, that's a big deal. Surprise. Yeah. So, one of the things that you'll see is you think about that. You think about your experiences when you're there with your patient and making sure that they understand. Let me give you an example. No, I'll talk about informed consent in a minute, but I'm sorry, I'm getting ahead of myself, and I don't want to do that. Sorry. I'll come back to that story. I'll tell you about the little lady with the gallbladder. So physically and mentally, the patient has got to be ready. That's our duties, right? So we're going to start an assessment. We've got to get them past medical history. We're asking everything. What is their general health? How old are they? If they tell you they're 67, ding, that's one check right there. One risk factor, right? The older they are, the less healing problem. They have more problems with healing, and they have a decreased immune system response. All right, so that puts them at risk as well. The fall charts? Yeah. That's part of what you do. It's part of what you do with your assessment. That's what you're asking a lot because you're looking at risk factors here. Yes, and that's part of what you're asking. Your organizations will have, your pre-op admission assessment. You know how you have a comprehensive adult assessment that we're making you do? Okay, you'll have that for patients who are admitted for surgery as well. To get all those risk factors and ask about all those things. So we're asking age. We're asking about the use of tobacco. Do they drink? Do they take drugs? Okay, because that may affect their response to anesthesia. If somebody's sucking up the Dilaudid every day at their house, Dilaudid in the hospital ain't going to work that well for them. We need to know that, okay? And the Lorcets and all that business, okay? So we need to know that. And we need to ask that in a non-judgmental way, okay? We're trying to collect data here. You don't take drugs, do you? And we don't ask that, but And I have heard nurses ask that. So what is the patient going to say? No. Okay, so ask them about those things. What are their previous hospitalizations? What kind of surgeries have they had? Okay, so not only do we have to ask that, but our next question is, did you have any complications from it? Okay, how did your surgeries go? Okay, so what did you have and how did you do? I would be interested in knowing why they had to intubate you if that was unplanned. You know, because we'll talk about some things that happen in surgery that are, hereditary and that we need to be prepared for. Things like malignant hyperthermia, life-threatening condition, we'll talk about it, but it is genetic. That's why we ask if your family's ever had any problems with anesthesia. Okay? But it's a life-threatening condition that is a response to certain medications. Well, if I know you have a risk of that, I'm not going to give you that medication. So history is important, very, very important. Anesthesia problems. So not only are we asking about surgeries, but we also want to ask them about any invasive procedures they've had, because they may have received a local anesthetic, a regional block, something like that. Did they have bad surgical experiences? Because if they did, they're probably not going to be quite as laid back and cooperative as you want them to be. Not that you can't handle that, but one of our duties is to try to reduce their anxiety. If they had a really bad experience, they may not. She's probably going to be a little nervous next time she has to have surgery. Maybe a little more than she was the first time. And that's normal. We need to deal with that. We need to ask our patients if they've had any implants, any new parts in there. We need to know that. Okay. Our patients are going to be hooked up to cautery pads and things like that. We need to make sure that we're not sticking those over implants and sending electrical current and all through them. That's not good. Okay, so we need to ask about things like that. Do you have, you can ask them about implants or artificial joints, things like that, and people who have had those things done, they know what you're asking, so they'll answer that. We want to ask them about pain control after their surgery. How did they do? Was pain control effective after surgery? Did they have a lot of nausea and vomiting post-operative? And it's funny, people who have had surgery that had a bad experience, you a lot of times don't even have to ask it. They'll tell you, I was sick as a dog last time I had surgery. They never got me to stop puking. They tell you things like that, so be attuned to that. They'll let you know. But just, it's probably going to be on your form to ask them. If they don't tell you, ask them. You need to know. We want to ask them about their allergies. Okay, what medications are they allergic to? Do they have latex allergies? We also want to ask them if they're allergic to shellfish. Okay, why? Iodine. Because one of the things that we do is we go back there and we just paint them all up and down with iodine. Or chloroprep. It depends on your organization, but betadine is still used. So we ask about that. Are you allergic to shellfish? Are you allergic to betadine, IV dyes, those kind of things? Okay. We got to know what medications they're taking. Every single one of them. Big, big deal. Things that we give them, we need to, be aware that they're taking these medicines. When was the last time they took it? Because our plan of care may change a little bit. Are they taking any over-the-counter meds? And are they taking any herbals? Your book, some of these herbals that people are taking will have an effect on them post-op. Your book has a chart on page 244 that talks about some of them. But things like garlic, people that take garlic, what it does, it inhibits their clotting. So that's why it's really important that we know if they're taking garlic. People may have put themselves on an aspirin every day, and they don't tell you that. That's just, I just take that. It's over the counter. But a lot of your patients will say, this is what I'm taking, and all they think about is what the doctor has given them a prescription for. So you have to delve a little bit deeper to get that information. Then we want to do a review of systems. You notice how we kind of do the same thing every time a patient comes to see us? Call the nursing process. There you go. Got to get the baseline. Get their history. Ask them about the review of systems. Do you have any cardiac problems? Do you have high blood pressure? Have you ever had any problems with your heart? Okay. Any kind of pre-existing disease. We got to know about those chronic conditions. Ask them about their respiratory status. Any pre-existing problems there? Okay. Have you had any shortness of breath recently? Any kind of cough? If it is it productive? Are you coughing anything up? Those kind of questions. Okay. So you just go down the list, taking each body system and asking them, have you ever had any problems with these things? The urinary system, do you have recurrent urinary tract infections? Some of your patients come out of surgery with the catheter in. And we don't want the catheter to stay in there any longer than it has to. But in the case of recurrent UTIs, we really are going to be diligent in getting that catheter out of there. Okay. Do they have renal failure? Remember we talked about yesterday, Monday, you might have to decide when I need to bladder scan somebody. If they don't have an output, once you take that catheter out, you're not going to be that concerned if they have renal failure. Okay. Looking at their endocrine system, do they have diabetes? And here's one of those things that you really want to know what their medical therapy is for diabetes. What kind of medicines are they on? Do they take insulin? If they do, how do they take it? When do they take it? What is their dosage? Blood sugar affects everything. Everything. Asking them about their thyroid. Metabolism is one of the things we want to check after surgery, making sure that's working. That's important. Okay. Hepatic. What do I want to know about hepatic system? Any kind of liver problems, liver disease, right? We've hopefully already asked about surgery, so we know if they've got their gallbladder. Okay. So a lot of your drugs, you remember, are synthesized through the liver. If they're in liver failure, that's certainly going to alter the way that we're going to give them their medications and what we're going to give them. Look at the musculoskeletal system. Do they have any problems with mobility? One of the things we'll talk about is getting that patient out of bed. We don't let folks lay in bed anymore. They got to get up. They hate it, but they got to get up. So if there's a mobility issue, we need to know about it. We need to make sure that our patients have their crutches and their canes and their artificial legs, whatever it takes to get them out of that bed. Okay, they need to bring them with them to the hospital. It also lets you know if there's any problems in positioning your patient. We'll take a look at some of the positions that we put patients in for surgery, and when we, if I've got a horrendous back, I can't be hanging from a toenail, so you need to know that. You need to know that so that you're, not causing any other problems by positioning your patient. Integumentary system. Ask about the history of any kind of skin problems, rashes, infections. We want to know if they've ever had any kind of problems with pressure ulcers. Why in the world would I want to need to know about that? They're just having a surgery procedure. Because they're laid out and they're not moving. Right, they're not moving. And so they are dead weight, and we have to be cognizant of that fact of how long that patient is laying there. So extra padding may be needed for those folks. And of course, we're going to ask about the immune system. Do they have any problems? Are they on chronic steroids? Okay. Why am I concerned with that? Right, it affects their healing. Okay. Are they taking any immunosuppressive drugs? Okay. That increases their risk for wound infections. So just a generalized review of those body systems. What have you had in the past? What do you have now? And now we got to get into our assessment. We've asked the questions. Now we got to get into checking on them. Yes. Mm-hmm. Mm-hmm. Intubating. Yeah. When you're going through your history and going over those review of systems, you're asking those types of questions. I just don't have it here. But yeah, you're concerned with, do you have any respiratory issues at night? Sleep apnea? Do you use, are you using CPAP at night? Yeah. And who's going to be really interested in that information? The anesthesia people. So not only are you doing a history and a physical, okay, on admission, but before your patient goes and has their surgery, anesthesia will come in and talk to them as well, and they will really do an in-depth interview on respiratory, cardiovascular, those body systems and that history, because that's primarily what they're looking for. Okay, so they will ask those questions. You will ask your patient about safety risks. Okay, like Marcus was asking, do we ask about fall risk? Yeah, we do. We do. When we're asking about their current health and current conditions, chronic conditions, yeah. Okay, we're asking, have you been falling recently? Do you have any issues with, home? We're also going to ask about their situation at home. Who's going to take care of you when you get home? Remember when we talked about discharge planning, how that starts when the patient is admitted? We ask those questions. I've just kind of geared it in toward the surgical procedure, but you're still going to ask, at home, who's going to take care of you at home? Do you have the resources? And making sure that they do have them once they get home. Okay? So your physical exam, your head to toe that you're going to do on your patient, same head to toe that you do for everybody. However, what you may focus a little more in depth on is the area that's going to have surgery. Okay? So if I'm coming in for a knee replacement and you're doing my head to toe assessment, you're still going to listen to my heart, you're still going to listen to my lungs and, make sure I can do all this business. But you're also going to focus into my musculoskeletal system. What is the strength in my legs? What do I want to know about that? Think about 103. What do I want to know about the strength in legs? How do I check that? Right, you're checking it. Push against my hands. Don't let me put, all that business. You're checking it bilaterally. You're checking my range of motion, right? You're checking my circulation. Hopefully my toes are pink, right? Okay, so you're going to do a little more focus into that area so you have a good baseline there. Still going to look at everything else, but a good example of that is when you have patients come into the hospital, nurses do not usually check a lot of the cranial nerves, all that stuff that you guys were learning. However, if that patient is coming in for a neurological procedure, you're going to focus in on that. Okay? Cranial nerves is just not something in the general scheme of med-surg nursing that we check on everybody. Perla, yes. Follow my light and all, but when you're doing all the sticking your tongue out and all that business, you just don't do that a lot. But if it's a neurological procedure, I want to know, especially if I'm having head and neck stuff, right? So you may have to alter it just a little bit based on the part that they're working on. Cardiovascular, 30% of the deaths that occur from surgery are due to cardiovascular events. That's where some of your skip measures came from. Okay? People were having heart attacks after surgery because we were holding them NPO and not giving them their beta blockers and not giving them their blood pressure medicines and all that business. We were not giving them anticoagulant therapy, so they were having clots, things like that. So cardiovascular is a big issue post-op. That's when we started some of those things. So we're checking for blood pressure problems. We're assessing to make sure that they have good blood flow to all extremities. Respiratory, when I assess the respiratory system, I want to know, is it good, normal effort for the respirations that they're taking? Are they coughing? Are they wheezing? What do their lungs sound like? How do you know if a patient has had chronic oxygen deficiency? Barrel chested, yeah. Okay, that's good. I wasn't thinking that one. That's good. Huh? Not necessarily capillary refill, but you're in the area. Clubbing, remember this business? Okay, so you're looking for that when you're assessing. Right. Okay, we're looking at kidney function. What is their intake and output? Right. Do they match? Does intake and output match? Are they pretty close? Yeah. You may have to ask your patient, are you getting up at night? How much do you pee during the day? You may have to just break it down that way. Void, they may not know what you're talking about. Looking at their neurologic function, what is their mental status? What is their level of consciousness? If they're kind of loopy now, they're really going to be loopy after we snocker them with morphine. Okay, so let's compare. Are they alert, oriented times 3, person, place, time? Right? Y'all remember all that from assessment? Is it coming back? Okay. Do they have the ability to follow your directions? Or is there some type of sensory detail there that they are not able to? They can't see, they can't hear. Okay. Of course, we're assessing musculoskeletal. With the head, neck, we want to make sure that, air passages, checking their carotids, not at the same time. Of course, that's the way I demonstrate it. It's like that. We're also looking at their skin. We've already asked them, doing the review of systems, but we've still got to assess. We still got to look at them. Do they have a red place on their hip? We need to certainly document that. Skin is one of those things, guys, that has kind of come full circle in the scheme of nursing. When I first got out of nursing, you flipped everybody every 2 hours. It didn't matter what was wrong with them. It didn't matter if they could turn themselves. You walked down that hall and you made sure everybody turned every 2 hours. Okay? You didn't have skin breakdown. Okay? And in the scheme of things, that kind of, unfortunately, fell by the wayside as nurses and techs and all got so involved in other tasks that they had to do. It's a sad fact. But, just trying to do the things that we have to do, that's one of those things. And so people started having wounds again. Okay, so that's another one of those core measure things that has come out, that we're not paying you if a person gets a skin breakdown in your hospital. That's poor care. We're not paying for poor care. So that's why now everybody that comes in, we do a very detailed skin audit on them. You guys may next year get to go to one of the hospitals and help with skin audits on every patient in the hospital. They do that now. They just peel everybody's clothes off and look at them. Okay? And they need lots of people to do that. So the second level people did that this past semester in the spring. They went to Huntsville Hospital and they looked at everybody. So skin is a big deal. Look at your patients. Make a notation if you see anything. Okay? That way we know it's there preoperatively. Okay? Now, so we've done our physical assessment. We'll take a break in a minute, guys, okay? We've done our physical exam. Preoperatively, we're going to do some diagnostic testing, okay? Got to do that business, right? And it's sometimes just the basic stuff that we do. That's another one of those things that has come full circle. Everybody that came in the hospital used to get a CBC and a UA. Didn't matter if you came in because you stubbed your toe, you got a urinalysis and you got a CBC. Well, people said, well, we're not paying for that. They don't need that. So they stopped doing that on everybody, but now they want to make sure that they don't have a kidney infection when they come in, and that they're not anemic when they come in, so they're starting to do that again, okay? But surgical procedures, you need to know what those baseline data numbers are, okay? You don't want to send your patient to OR with a raging urinary tract infection, because what happens is your patient can turn septic very easily. Okay, so we're doing UAs. We want to make sure that they don't have a lot of sugar in their blood. In their urine, because that means their blood sugar is all out of whack. Okay, we're doing blood typing and screening in case we need to give blood transfusions. CBCs. What is a CBC? Complete blood count, great. Hemoglobins, hematocrits. Why in the world would I want to know PT and PTTs and INRs? It's their clotting ability, right. That's important. If I got a patient who's not going to clot, I don't need to be taking them to surgery, okay? Looking at their electrolytes. Potassium is a biggie. Sodium, it's a biggie. Okay. If you have a patient with electrolyte imbalances, especially potassium, that patient will not go to surgery until that potassium is taken care of and in normal limits. Do you know why? Well, let's maybe not die, but what they can have, what kind of cardiac? Potassium affects the cardiac muscle, right? So we'll get that in got to get that in good levels there. We're looking at creatinine and BUN, which tells me about their kidney function. Some of our medications are excreted through the kidney, so we got to make sure that's working. Why in the world would I want to do an HCG? What in the world is that? Pregnancy, right. We got to make sure that's not an issue. We're doing EKGs to look at cardiac function. And then, based on what your patient is having, I'm sure they've had all sorts of scans, x-rays, maybe an MRI. A lot of people just get a baseline chest x-ray prior to surgery because the risk of pneumonia and fluid retention and all that business is high after surgery, so they want to make sure they don't have anything going on there before they actually do the surgery. Do we need a break? Okay. So we've done our physical assessment. We've done our, hopefully we've got all our labs, got all our diagnostics. We're also assessing our patient's fluid and electrolyte status. When we're assessing that, not only are we looking at their blood work, but, we're wanting to know, are they having any kind of issues with nausea, vomiting, GI disturbances, all those things that cause them to lose fluid and electrolytes. Do they have difficulty swallowing? We want to know, are they taking diuretics that's pulling off their fluid and electrolytes? And just know, with your elderly folks, they are much more sensitive to fluid and electrolyte loss and maintaining those levels. So that's another risk factor that they have added on to them. They don't keep it in check, like they used to. We're looking at our patient's nutritional status. We need to know if they're above body requirements or below body requirements. Okay? Patients that are overnourished, obesity stresses their cardiac system, their respiratory system, and it's more difficult to assess the surgical site. So your patients that are obese postoperatively, they have issues with wound healing. They have a bigger risk of dehiscence, which is what? When the wound opens, and evisceration when the stuff spills out. Right? Dehiscence, and then the spilling out of the organs is called evisceration. With more. This doesn't sew together as easy as it is if it's not all this under it, okay? So just being overweight puts them at risk for wound issues, for pneumonia, respiratory issues post-op, cardiac issues post-op, they don't want to move. They don't want to breathe. I want to be lazy. And give me my pain medicine. Okay? Now, those patients who are malnourished or undernourished also have risks as well, because they have a lot of issues with fluid and electrolyte balance. Okay? They may not have the vitamins on board, A, B, C, that help with wound healing. They may not have enough protein stores to help with wound healing. Also, in the folks that are extremely malnourished, just know that they have a bigger risk for skin breakdown. So extra padding is needed under those bony prominences there. We're also assessing their psychosocial status. How anxious are they? Okay. What is their ability to cope with this procedure and the care afterwards? Okay. Some of your patients are going to be so devastated by the procedure that they've got to have, or devastated because Aunt Martha's sister didn't ever come out of the hospital when she had that surgery. You know, all they hear is horror stories, that they can't focus on what you're trying to teach them and what you're trying to do. Okay, so just know that you're going to have to alter your interactions with them, okay, to try to handle some of that anxiety that they have. Can they cope with it? Do they have the mental capacity and the resources to take care of themselves post-op? We need to know that beforehand. We don't want somebody's discharge. It doesn't mean that we're not going to do the surgery. You know, if the patient agrees to it. But, you know, we don't need to have a discharge delayed because we haven't got the proper resources for the patient to exist at home or go wherever they need to go. Okay? Discharge planning starts on admission. We also we're going to do a safety assessment. Have they been falling? What is their gait? Can they walk by themselves? Can they sit up by themselves? Any history of falling? So when I said we check everything, right? Gotta have that good baseline. Okay. All right. So now we've got to do some pre-op teaching. That's a huge, huge aspect of your pre-op care. Why in the world? We want to increase the patient satisfaction. I don't know that they're going to be satisfied, but relieving their anxiety, decreasing their stress. If they know ahead of time how to prepare, what we're going to do, and what to expect, it decreases their complications. They're more cooperative with you. Okay? Decreases their anxiety, their fear. They get better quicker. They get to go home. Their length of stay is decreased. And their recovery time, once they get home, is shortened. So something just as simple as taking the time to explain to your patient what they can expect just works wonders with their care and how they cooperate with you. Okay? Now what you have to be careful about is that you're doing teaching in the proper manner. Okay? Are we going to talk to these people like we would Nana? No, we're really not. Okay? This is my niece right here, and you can't tell her anything. So with children, when you're doing pre-op teaching with children, consider the age, consider the parents. Okay? Sometimes the kid is more calm than the parents are. Okay? So you've got to adjust your teaching. You need to teach at the level of their understanding. Go back to your growth and development. Okay? Think about some of those things. How you communicate with a toddler as opposed to an adolescent. Now, you're not going to be explaining a surgical procedure to a toddler, right? But we do need to make sure that we use terms that they understand. Okay? Because we are going to take them away from mother and daddy. Okay? They need to understand that. Teaching according to their developmental age. Use concrete terms and appropriate terminology. for the age group. Okay. So you'll hear people say things about, we're going to have you breathe fairy dust, and you'll be sleepy, and sometimes when you use the words, we're going to put you to sleep, to a kid, all they can think about is that the dog got put to sleep. And the dog didn't come home. So be careful about things like that, okay? Oops. Allow, if there's something that they're going to be doing ahead of time, pre-op or post-op, give them time to practice, okay? If they're going to be doing incentive spirometry and breathing in that machine, let them practice that so that they see it's not horrible, okay? Be honest with your children. Don't tell them surgery's not going to hurt. Yeah, it does. So they come out and you've completely destroyed the relationship with them because you said it wasn't going to hurt. Okay? Now, you don't have to say it's excruciating or anything like that, but you're going to be sore. We've got medicine for that. Explain yourself. Okay? But don't tell them it's not going to hurt. Be positive. Okay? Even if the surgery that they're going for is, you don't know what the outcome is going to be, we still need to be positive. We need to present that to their parents as well. Okay? Be available. When you're doing pre-op teaching for a pediatric patient, you need to set time aside to do that fully and not rushed. Okay. How many of you have had children that have had surgery? Yeah. It's a big deal for you, isn't it? Yeah, it's bigger for you than it is for them. Yeah. So, just realize that. Mom and Dad are going to have a whole lot of questions. Okay? And that's fine. They should. Okay? When we're talking with the elderly, what kind of communication techniques do we need to use? We need to be slow. What else? Make sure that they can hear you. I had a little lady one time. I don't know if y'all know it, but I'm kind of a loud individual. And so I was talking to her, and I was doing her teaching. And I'm just talking, and I've slowed it down and all. And I said, do you have any questions? She said, honey, I am not deaf. So, okay, I'll tone that down a little bit. So not everybody's deaf, okay? But speak slowly, speak succinctly, make sure that they understand them. Allow them time to answer questions, okay? Make sure they understand. If you need to write it out, write it out. And a lot of places now, pre-op instructions and teaching is written out. You go to your pharmacist now and you get a prescription filled. What do? They hand you an instruction sheet. Okay. Have you ever looked at that stuff? Yeah. It's pretty simple verbiage, isn't it? Because the average individual reads at a 6th grade level. So that's what a lot of your discharge instructions, pre-op teaching, informational things that you get are written for that level. So with the elderly, we just got to make sure that they understand and that we take time to teach them. Are these not the cutest things right there? I hope to goodness that's me. I'm getting me a hat. I'm getting a hat. So, isn't it darling? And look at her on that computer. Bless her heart. You've seen the commercial where the woman's got the stickies all over the wall. That's not how it works. I think that is so cute. The elderly, that's my group. I love working with them. They're so funny. Correct. Yes. Shh. Uh-huh. They don't go to the doctor, right? They didn't go to the doctor, right. They didn't have money and they didn't have time. They had to be in the fields and, but yeah, they come at it completely different. You're right. They sure do. So what do we teach? Everything. Pre-op teaching may be done before your patient comes in actually for the day of surgery, and we want that done in time for them to assimilate this knowledge. Okay. We've assessed their level of understanding, so we're grooming our teaching session to meet that. But your patient needs to know what times to be there. Okay? They need to know the date. They need to know the time. When do I need to show up? You can give them a roundabout time of when their surgery may be. Please make the comment to them that surgical schedules change. I have seen some very irate patients because they thought they would have surgery at 9 o'clock. Well, here it is 11. Okay? They need to understand that their times may change. What is the schedule of events? Okay, explain to them you're going to come in at 6 o'clock. Meet the admissions person. They'll complete some paperwork. Then we'll take you up to the unit, put you in the bed, let you change clothes, and then we'll get your IV started. We'll have a bunch of questions to ask you. Hook you up to the monitor. What's going to happen that morning? Okay. We'll give you some medication if they have a pre-op order. Let them know. Let them know what the plan is. We want to assess not only, guys, what their understanding level is, but we've also got to kind of look at, are there any barriers to learning? Okay, what would be a barrier to a patient learning? Language, absolutely. Language may be an issue. What else? They can't hear you. They can't see you well. Culture, absolutely. So you have to assess those kind of things as well. So when you're looking at that psychosocial business, and I said that there's other questions that I didn't cover. In your admission assessment, that's one of the things that you'll ask them. How do you learn? Do you learn best by written, by doing, by seeing, that kind of thing? Remember we talked the other day? You guys learn in different ways. Your patients do too. Okay? So I can't give a handout with size 10 font to somebody who has glasses that thick. Okay? I need to think about that kind of stuff. So we've got to assess those barriers. Are they there, and how do we need to adjust it? We want to make sure that the person understands the procedure. Ask them, what procedure are you having? Okay. We make sure that we talk with them about the consent, which we'll talk about in a minute. We're going to talk about any kind of admission requirements. Make sure that when you come that day, you bring your driver's license and your insurance card. Any kind of those requirements that they need. Bring your cane with you. Bring your dentures with you. All that kind of stuff. Make sure that they understand the pre-admission preps that they're going to have to do. Some patients have to have bowel prep starting anywhere from 24 to 48 hours ahead of the surgery date. So we need to make sure that they understand how that process works. And we do need to tell them if they're going to have enemas when they get to you that day. Okay? Trust me, if they're going to come in and you're going to have to give them enemas, you need to make sure they understand that 2-day prep. Because you're going to be enemying all day long. Okay? So make sure that they understand what they got to do, what times they got to take it. Make sure they understand that they need to be on clear liquids. Yeah, I'm doing my prep, but I had a steak and baked potatoes. No, that's not the way it works. Okay. And again, if you can write that down, that helps, okay? Because surgery will be delayed or rescheduled if they're not prepped appropriately. You can't do it. You just can't do it. And I've seen some people mad about that too, but you had a steak and baked potato, hey, I didn't cook it for you. You ate it. So, you just got to make sure. That's why when they get there that day, we're going to ask them, when's the last time you ate or drank? What did you eat or drink? Okay. Your patients need to know about their prep. They need to know about their nutritional rules. We used to just keep everybody NPO at midnight, the night before surgery. Didn't matter what you was having. If you were going to have anesthesia, you were NPO at midnight. We took your water away and took your picture out of the room or turned it upside down. They don't hold people NPO after midnight a lot anymore because what they found out is the elderly were not being able to maintain their blood sugars and their electrolyte balances. Okay, so now it just kind of depends on the type of anesthesia that's planned, the type of surgery. Okay, basically they don't want people to have any kind of solid food for at least 6 hours before their surgery. And I'll tell you, I'm not going to hold you guys to asking you a question about 6 hours versus 2 because it's really kind of up in the air now. There's no one set rule. Okay, so just know that your patient is going to be NPO for a period of time before they have their procedure. Okay, right now data is just all sorts of numbers, and people are anesthesia's doing what they it's the physician's call. Okay. So your patient needs to understand when. After 2 a.m., you cannot have anything else to eat or drink. And don't say nothing NPO. They don't understand that. Okay? If they're going to be on clear liquids, they need to understand what clear liquids is. Okay? What is clear liquids? Water, broth, Jell-O, anything that you can see the bottom of the cup through. Not milk, not pudding. It's amazing what they come up with, really. Okay. All right, so they need to understand their preps. They need to understand their nutrition things. We really do not hold people NPO for more than 8 hours anymore. That's kind of the standard. We try not to do that anymore. They need to know about their medications and what to do about their medications. All right. When we held people NPO at midnight, that means nothing. They didn't take their meds. They didn't do anything. So we had people having all these events during their surgeries and after their surgeries. So here's where Skip rolls in and says, oh, no. It's okay for them. Let your patients who take blood pressure meds, who take beta blockers, your patients who take ARBs, give them their medicines in the morning with a sip of water. Okay? Now, this is anesthesia's call, usually, on what medications they want them to take. But as a rule now, generally people get to take their cardiovascular meds. They get to take their thyroid meds. They do not get to take their anticoagulants unless that is strictly ordered. Okay? In fact, most of the time, your anticoagulants are stopped several days before surgery. Aspirin is usually stopped a week ahead of time, 7 days. Coumadin, they may wait 3 to 5. But again, that's physician preference. Okay? So those are stopped. But the other things they may be able to do, and you should have an order or a standing protocol, something like that, that says what they can take and what they can't. Now, the difference to that is their diabetic medicine. Okay, their insulin, their glucophage and glucotrol and all that business. That needs to be looked at on a person-to-person basis. Okay, so if we let them take their they can take their insulin that morning. Okay, insulin does what to blood sugar? Drops it. Okay, so we let them take their insulin, and then they're in surgery for 2 hours, and then they come out and they're in recovery. They're schnockered for the next 8 hours. What's their blood sugar doing? Right. So we have to look at, that you have to know ahead of time. You can't just say, go ahead and take your insulin. Go ahead and take your glucophage. Okay. We ask that pretty much on a person by person. Seizure medicines, we usually let them take their seizure medicines. But again, if it's not written for you on what to do with their daily medications, I would call and ask, because that's one of the skip things. They need to have it, and if they don't have it, there needs to be documentation by the physician about why that wasn't given pre-op. Okay. We ask our patient in pre-op teaching, especially if they're coming in as an outpatient, how are you getting home? We don't let people get in their cars and drive themselves home. Okay, they must have a driver. And then we want to know who's going to be with them. Usually we like people to stay with them for the first 24 hours. That's not always an option, but you can't control that, all you can do is just inform them. But we do not let people out of the hospital to get in their cars and go drive. They just have to hang till somebody shows up. So that's certainly a huge liability issue. Questions about that? All right. One of your big duties as far as your pre-op teaching is obtaining informed consent from your patient. Okay? Informed consent is really something that we don't do that just because they're having surgery. We get informed consent for all kinds of invasive things. Okay? Pretty much everything requires a consent except for putting in an NG tube or putting in a Foley. That's considered basic nursing care. So when your patient signs the form, yeah, I'll come into your hospital, they're agreeing to basic nursing care. So, but pretty much everything else, you need to get a consent. And the procedure is the same. Whether it's for an x-ray procedure, a bedside procedure, or a surgical procedure. Okay? The purpose of it is to ensure that your patient understands what they're having done and the need for the procedure. That they have been informed about why they need to have the procedure, the name of the procedure, what are the risks, the benefits, what kind of alternative therapies they could have. And the expected results. Yes, sir. Sure. To ensure that the patient understands the need for the procedure, the steps that are involved, the risks, the benefits, any alternative therapies, and the expected results. Now, it is the physician's responsibility to do all of that. Okay? Now, not yours. Legally, the physician is responsible for explaining all that to the patient. Your responsibility is to make sure that the patient understands that. Okay? You have kind of an ethical responsibility to verify that the patient understands it, and then to have them sign it. Okay, so when you're witnessing a patient's consent form, you're just witnessing that that's their signature. Okay, but ethically, you don't need to get their signature unless you're sure that they understand. Let me give you an example. Here's my lady with the gallbladder. Had a little elderly lady. She was mid-70s, 80. She was on up there. And she needed to have gallbladder surgery. Okay? The surgeon came in. He talked with her. She had been in a couple of days with abdominal pain and all that, so she'd been there. So he comes in to talk to her, and he tells her, well, your gallbladder's bad. You need to take your gallbladder out. And he did a beautiful job of explaining to this woman what she would have. She would have it laparoscopically, which is the little small incisions. And if it was too huge that he couldn't get it out there, he may have to do an incision, open her up. She would have a longer incision, yada, yada, yada. He did a beautiful job. What to expect, what else alternative therapies, what the recovery was, just did beautifully. She was looking at him. She was smiling. She was shaking her head. Yes, sir, yes, sir, yes, sir. So he says, okay, I'm going to go ahead and schedule it for first thing in the morning. We're not going to let you have anything to eat or drink in the morning. Let you have your meds with a little sip of water. Do you have any questions? No, that's fine. Thank you so much for coming back. Okay. He leaves. We walk out of the room, and he says, get her consent for, okay. I said, okay. So I go back, and I fill out the thing, laparoscopic cholecystectomy, potential for, possible open chole, that kind of thing. And I go in, and I talk with her, and I'm like, okay, so you're going to have surgery in the morning. And yes. And I said, what are you going to have? He's going to take my gallbladder out. I said, good, okay. So I knew she knew what the surgery was. And I said, well, do you have any questions? No, just pleasant as she could be. And I said, okay, well, I'm going to need you to sign a consent here, saying that it's okay for Dr. So-and-so to take your gallbladder, and that you understand that he may, if he can't get it out with the little incisions, that he may have to do a larger incision. Okay. So she has the pen, and she's fixing to sign, and she says, can I ask you something? And I said, sure. And she said, honey, if he takes my bladder out, how am I going to pee? Did she understand what she was going to have done? No. I can see her to this day, and that's been several years ago. But, honey, so what do you do in that case? Yeah, if you're comfortable explaining that and validating her information, correcting her understanding, that's fine. You can do that if you can do that appropriately. If you don't think that you can, you just need to say, okay, let's step back and call the doctor and say, she has not a clue what you're doing. She does not understand what you said, but I felt comfortable in what he was going to do, so I explained to her the difference between bladder and gallbladder. So she signed the consent, she had it, she was fine. But, ethically, I don't care how big of a hurry I was in, you can't let her sign that. She did not know, because she was expecting bladder down, not up here. Or I guess she knows this. I don't know. She didn't know there was two bladders there. No, I was in the hospital. She was in there. She had been in for a couple of days for abdominal pain. That's what she came in for. Honey. So, anyway. So, you're responsible for making sure that they understand and getting their consent. Now, who can sign the consent? It needs to be the patient, if at all possible. Okay? Some people are not capable mentally or physically of signing a consent. You just have to know your organization's policies regarding that. But most of the time, a patient, if they can't write, they can make their X. Usually 2 nurses have to witness that that's their X. Okay? A next of kin, can sign if the patient is unable to sign. But if it is a competent adult, they need to sign it. So somebody that's a minor, and I think age of consent in the state of Alabama is 14. Yeah. However, if that patient has had a child, and there are 12-year-olds out there with kids, if that patient has had a child, they have graduated from high school, or if they are married, they can sign their own consent. Okay, so but age 14 is the age. There again, though, when you start talking about 14-year-olds, you really have to make sure, do they understand? You know, they can sign their consent. But, you know, do they really understand what they're consenting to? If you have a true emergency, okay, that precedes consent. Okay? Physicians can do immediate life-saving interventions without patient consent. However, there has to be documentation and usually a signature of another physician saying that we've got to do this or the patient will die. Okay? Now, they're not doing that ahead of time. You know, there's usually a consult and the patient is whisked off to surgery or whatever. But in the case of a true life-threatening emergency, consent can wait. Okay? It is okay to get phone consent. If you have a little elderly patient and the healthcare power of attorney lives in Arizona, get her on the telephone, 2 of you on the phone listening, making sure that they understand. Hopefully the physician has talked to the next of kin. But you can get phone consent. Again, needs to be 2 people signing it, 2 nurses witnessing it. And you just write phone on the consent, phone consent obtained from whoever the person is, what their relationship is, and both nurses sign it. Okay. So you can get phone consent. They can make their ex, emergency, what other kind of consent. It should be you'll have to see what your policy is, but most places, I believe, it would require somebody else to say, hey, this is a life-threatening condition, that if we delay and by trying to get consent, the patient will die. No. 2 nurses need to sign because there's not an actual signature. Anybody's signature is there. Nothing. That covers you. Usually you have on file, because remember, when your patient comes in, one of the first things we ask them is, do you have an advance directive, and do you have a healthcare power of attorney? Remember, we ask that on usually your admission people are asking that before they even get to you. So if they have those advance directives, we usually ask them to have a copy, and we have that on file. At my hospital, we keep it on file. So when they come in, they say, yeah, I have one, and I gave you a copy last time. We get a copy from medical records, and then we make sure there's been no changes. Yeah, the 2 doctors have to agree, have to say that it's okay. Yeah, that they got to do it. But if you only have an X or you have no signature, then 2 nurses need to verify, a witness that somebody gave okay to do that. Yeah. Okay. And then there should be on file too who their next of kin is. Okay. And whoever has healthcare power of attorney tops next of kin, provided you got the papers. You go to a lawyer and have them drawn up. They draw up those papers. Okay. So, who can witness and inform consent? Only a licensed healthcare provider, okay, can witness an informed consent. A family member cannot. So your PNs, they can witness. Your techs cannot. If you have that barrier of language, you must have an interpreter. Okay. Just keep in mind that usually your informed consent covers everything. However, there's also consent for anesthesia, and there's also blood consent. Usually there's separate consents for those two things. Okay? I think your book has an example of an informed consent form. Page 251. So you can take a look. They vary from place to place, but they're essentially the same. I, such and such, agree to let such and such do such and such. I understand the risk, benefits, yada, 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 yada. Yes, ma'am. Can a blood consent be overridden during surgery and in an emergency, and do they need to tell you after surgery? Are there, yeah, boy, you better tell me if you gave me blood. What do you mean, can it be overridden? Because if you haven't given consent to surgery, you haven't given consent to blood. If you're that critical, they will do immediate life-saving thing, because if you've come in, that's implied consent. They will take care of you, okay? Save your life. Then they're not signing blood consents, and they don't get blood. No. No, that's part of your pre-op teaching, the whole blood business, and so they should understand whether blood is going to be a potential factor in their surgery or not, okay? Then they're usually told, now if something happens, we may have to give you some blood. Do you consent to that? And they say yes, you sign that. They're typed and cross-matched. Okay? If they say no, they say no. Then that's emergency. If it is not immediate life-saving stuff that you got to whisk them to the OR, then that patient will be stabilized, family will be contacted, consent will be obtained, blood will be discussed, and then the patient will go to surgery. They don't just bring folks in and take them to surgery unless it is, like I said, two people need to agree that, hey, if we try to find family, this patient's going to be dead. You can't unless the patient is the one talking. Okay? The patient, I don't know what their wishes are. They're unconscious. So you have to go by next of kin. If the patient is competent to give you their consent, they have a right to refuse. It drives us nuts, but they have a right to refuse. So you're not making that decision. You're not making that decision on care. Okay? That has to be the physician. How vital is this that we disregard what this family member says? You know, that you're not making that decision. Okay? Now, are you always going to agree with the things that the patient and the family say? No, you're not. Just like we said that those conflicting things that you have to work through, but you have to cover legally what can you do. And again, it's not your call. Okay? You just need to understand it. However, if you ever have things like that come along, your organization has legal representation, usually through your risk management department. And so if something happens like that, go to your next chain in the chain of command and say, this is what's going on. I have an issue with this. She's his legal next of kin, and if he can't speak for himself, that's who I'm asking. So how do you take care of that? You get an advance directive, and you divorce her. You get her out of your life. Yeah. But that's all you have to go on. As a healthcare provider, that's all you got to go on is the next of kin. You know, so. Okay. Lot of legal and ethical issues when you start talking about consent. But what is your responsibility? To take care of the patient, make sure the patient understands, and then you get it signed. Okay? Now, so with the informed consent, you're probably filling it out, okay? So make sure that you're writing the consent in layman's terms, okay? There have been lawsuits because patients have signed a consent that had medical jargon on there, and they thought they were signing something else. They thought they were consenting to something else. So write it in words that your patient understands. Don't write cholecystectomy. Removal of my gallbladder. Okay? All of the information on your consent has to be correct and thorough. If you make an error in filling out the consent, how do we usually fix errors in medical documentation? Line through it with your initials, right? If you have not gotten that patient to sign it, rip that up, throw that away, and get you a new one. Okay? No errors on that consent before that patient signs it. Don't even open yourself up to that question. Okay? Their signature demonstrates that they have a clear understanding and comprehension of the information. So you ask them, just like I asked that lady, what did the doctor tell you he's going to do? Okay. What did he say would happen after surgery? Just taking those few little extra steps will make your job so much easier down the road. Okay? Their consent has to be voluntary. If it's a competent adult, anybody signing the consent, it has to be voluntary. We can't make somebody have the procedure that we want. And we shouldn't be getting consent signed from somebody whose daughter is making them have the surgery. Okay. And it's not that we refuse to get it signed, it's just that we need to talk with some other people about, hey, this is the situation that I have going on. Okay. We need to let the physician know, hey, and then somebody else is going to make that decision. Again, you're just making sure that everything is okay and getting it signed and witnessed. Okay? It's not your decision on whether they need to have it or if they need to, the daughter needs or the wife needs to step out. That's dynamics you don't want to be involved in. Patient, it needs to be voluntary. It must be signed before you give your patient any kind of sedative or pre-op medication. You cannot have a snockered patient signing informed consent. I did this. They weren't happy with me that day. We were in a hurry. I went running in there. Okay, I need you to sign this consent. Not knowing that my coworker had run in there about 10 minutes and popped her with a bunch of Demerol. Oops. So, yeah, they weren't happy. What happens is you really can't do the surgery. You have to wait until your patient's unsnockered to get them to then sign the consent. Then they can go to surgery. Huh? Oh, they were mad at all of us. I didn't lose no sleep over it. I mean, it wasn't like I intentionally did it, and she didn't intentionally. They said, get this patient ready. Well, she was ready. Maybe not in the steps we needed to have done it, but she was ready, by God. And not only is informed consent the issue, but anesthesia needs to talk to them. Okay? So if they're sedated, they can't really talk to them about their anesthesia. That's the people that really go crazy. Okay? But legally, you're not covered if your patient has had their pre-op meds. Okay? Yeah, boy. She got it twice. So, if that's the only mistake you do, life will be pretty good. Life will be pretty good for you. Informed consents go in the medical record, and they go with the patient chart to surgery. That's one of the things that they're really going to look at when they get back to surgery, to make sure that the consent is signed, dated, thorough, done. Okay? All right, so we've got informed consent. We've done our pre-op teaching about what to expect pre-op. We also need to tell our patients what to expect post-op. Do we need a break? Y'all want a little break? All right. Let's stop here.